I'm Dr. Peter McCullough. I'm a practicing internist and cardiologist in Dallas, Texas. I'm also trained as an epidemiologist, and I've been active in the field of internal medicine, cardiovascular disease, nephrology, and the last 4 years in the pandemic, and have become in many ways an infectious disease expert on SARS-CoV-2 and a vaccine safety expert on the consequences of what we're seeing in the COVID-19 vaccine campaign. And with over 70 peer-reviewed papers on the pandemic, I have really, I think, led a capstone manuscript. And the first author is Nick Holscher, who's a graduate student at the University of Michigan. He'll be joining the McCullough Foundation later this year as our first clinical scholar and fellow. And the paper was published in the European Society of Cardiology, one of the top cardiology journals. We synthesized and brought together all of the autopsy results from fatal cases of COVID-19 vaccine-induced myocarditis. And what we found is majority of cases were isolated just to the heart. There was just 1 or 2 cases where it was part of multi-system inflammatory disease. About 2/3 were with Pfizer and the rest with Moderna, and I think just 1 with a non-messenger RNA vaccine. Sadly, none of the cases had a chance ahead of time to have an MRI or an evaluation to detect myocarditis, and the first manifestation was death. And most of the time it was cardiac arrest or sudden death. This paper was first in preprint form on the preprint server, and now has been selected among the most downloaded and read papers on the preprint server. There's currently a vote underway for the overall top paper, and our paper is in the lead by a great margin. And it was published, as I mentioned, in the European Society of Cardiology Heart Failure Journal. And in that journal, it has the #1 number of downloads and reads of any paper in that journal in the last 2 years, and it's only been out about 2 weeks. So this is the first definitive evidence that without any question, the COVID-19 vaccines are leading to sudden death. And it applies to the next sudden death that happens in a patient who took the vaccine, and there's no antecedent disease nor their explanation. They simply were vaccinated and had a cardiac arrest. The results of our paper, Holscher and colleagues, published in the European Society of Cardiology, they apply. It is the vaccine as the cause of death until proven otherwise. The implications of the paper being in a major journal, in this case, a European journal, is that both European, American, South American doctors from Asia, they read a core group of medical journals. And among cardiology meetings, the European Society of Cardiology meeting is actually slightly more popular than the American College of Cardiology and the American Heart Association meetings. So it means it's widely read. I did disclose it to the American College of Cardiology at the leadership level. I think they have an understanding of my safety concerns regarding the vaccines. And I think quietly, more and more cardiologists now are starting to understand that they took the vaccines themselves. They likely encouraged their family members to take the vaccines and their patients, and that they've made a grave error, that the vaccines were never safe. They're leading to record injuries, disabilities, and sadly, sudden death, autopsy proven, and they were never effective. They never reduced the rates of transmission of the illness or of hospitalization and death. And sadly, the vaccines currently in use today were never tested on humans before they were released for issuance in the population. It's unprecedented that the COVID-19 boosters were not tested in humans before they were rolled out. They make a new type of SARS-CoV-2 spike protein. In fact, the bivalent boosters made multiple different types of spike protein. We had no idea about the safety profile of these new products, and there was no medical justification for rolling them out. We're on the back end of the pandemic. We're into very mild strains of Omicron. In fact, as the boosters rolled out, they were covering Omicron substrains that were already extinct. So they had no chance of helping, and they certainly have had a great impact in terms of harming the population. There's about 800 papers in the peer-reviewed literature dealing with the COVID vaccine and the heart. And what we understand is there is a distinct syndrome of COVID-19 vaccine-induced myocarditis, probably where there's a substantial size of damaged tissue in the heart. That's enough to be clinically detectable. That is chest pain, EKG changes, elevations in cardiac troponin, abnormalities seen on echocardiography and cardiac MRI. Many times it's the outer part of the myocardium and the surface layer of the myocardium and its containing structure in the chest, the pericardium. So it's termed a myopericarditis. And what's known there is the messenger RNA is found in the human heart in a paper by Crossan and colleagues. The spike protein is intensely staining in the heart. Paper by Bohmeyer showed that in living tissue necropsies. And then there's inflammation. And the inflammation results in either an abnormal heart rhythm as the depolarization goes down through heterogeneous tissue and circles around. It becomes a reentrant ventricular tachycardia, degenerating to ventricular fibrillation and asystole as a mode of sudden death, largely triggered by adrenaline during sports or between 3 a.m. and 6 a.m. in the waking hours, or can result in heart failure if it's a substantially large area of myocardium. If it's a patient who previously had damage to the heart, and I've had a patient in my practice with one dose of Pfizer, he went into cardiogenic shock and required a heart transplant in assist devices, had a very rocky course. Well, at baseline, he had a weakened heart and he had prior bypass surgery and a defibrillator. That would be the last person we'd want to have any cardiologist recommend a vaccine, because if there is damage, as in his case, it's a catastrophe. Well, that's COVID-19 vaccine-induced myocarditis when it's clinically detectable. Two studies, one by Mansugian and the other one by Buren, demonstrate that occurs at a rate of about 2.5% per shot. So each shot offers that opportunity. 2.5% may seem low to the listener, but I can tell you from a population perspective, it's a big number. Low in any safety event should be way less than 1%. That's myocarditis. Now, there is a more broad condition that recently has been described, and that is a form that's probably subclinical myocarditis and reflective in abnormal cardiac metabolism. In a paper by Nakahara and colleagues, they found in everyone who had taken a vaccine, roughly 700 vaccinated versus 300 unvaccinated, and those who took the vaccine, the normal heart cardiac positron emission tomography appearance, where the heart favors free fatty acids, that changes to the heart favoring glucose. And the radio-labeled 18-fluorodeoxyglucose lights up like a Christmas tree. It's a very abnormal pattern. It's easily detectable. Those who had a sore arm with the injection as a proxy for potentially having more RNA or more susceptibility to this, they had even more intense uptake of FTG. It has a pattern that looks ischemic. And what we've never seen is global ischemia like this. And in a important paper published by David Scheim, former National Institutes of Health researcher, he's describing micro blood clots, small little stacks of red blood cells that are linked together by the vaccine spike protein. It's called hemagglutination. If there is micro blood clots or hemagglutination in the human heart occurring after vaccination, it would explain this dramatically abnormal PET scan pattern in the vaccinated compared to the unvaccinated. So I think the leading hypothesis here is that there are micro blood clots causing a global change in some, especially younger individuals, athletes. There's intense uptake of messenger RNA and production of spike protein, and there's direct cardiac inflammation. We are seeing cardiac arrest, though, in the absence of anatomic myocarditis detected either by MRI or at autopsy. And we're seeing cardiac arrests occurring now more than 2 years after the shots. So we understand that there is some residual risk, even in those who took the shots to a primary series in 2021 and 2024 today. I'm still worried. In 2024, as we sit here today, every cancer registry in the world is showing record numbers of new cases, both incidence and prevalence. We're also seeing record numbers of patients who had cancer in remission, and the cancer comes out of remission. So the question on the table is, what's changed? The deflection upward started in 2021. One explanation is that during the pandemic and lockdowns, colonoscopies, mammography, other cancer screening was delayed, and now we're just seeing a catch-up phase. I don't think it explains all of it. And now a paper that was published by Anguis and Bustos from the University of Oregon, I think sheds a lot of light on this. It was published in the PubMed peer-reviewed journal Curious. And the title of the paper is The Multi-Hit Hypothesis of Oncogenesis After COVID-19 Vaccination. What does that mean? It means the COVID-19 vaccines, largely messenger RNA vaccines, the messenger RNA itself can impair DNA repair. So it can actually begin to tip the scale towards cancer promotion in cells. The spike protein, the S2 segment, which one actually gets from the vaccine and not from the infection, the S2 segment in a paper by Singh and Singh from University of Pittsburgh appears to inhibit the P53 and BRCA tumor suppressor systems. Our natural tumor surveillance systems are impaired. And if one has a loss of function mutation in either one of these, a woman would recognize this as, quote, being BRCA positive. That would be a loss of function mutation in this surveillance system. That could predispose somebody to cancer, particularly breast and female reproductive cancers. And then lastly, a recent finding that the messenger RNA vaccines, both Pfizer and Moderna, have DNA process-related impurities. And at least 4 labs have described this. 2 papers, one by Spiegler and the other by McCullough, have identified elevated levels of DNA fragments and size of the fragments that are considered process-related impurities. They come from circular pieces of DNA used that have the code for the messenger RNA. They're in the form of a plasmid in E. coli. And the fragments that are detected are the SV40 enhancer, promoter, and origin of insertion, as well as an antibiotic resistance fragments that are used in the manufacturing process. The reason why SV40 is important, it stands for simian virus 40. This is a known proto-oncogene activator. So in summary, the COVID vaccines have at least 3 mechanisms by which they could start a cancer or they could promote an existing cancer, and it may occur more rapidly because tumor defense systems are taken down. That's what we call turbo cancer. Now, the first bona fide case of turbo cancer, I'm the senior author on the paper. The first author is Dr. Internist Karagakoulis from Greece. It was a man who took one COVID-19 messenger RNA vaccine and within a few days developed jaw pain. And ultimately, he was detected to have an invasive basaloid cancer. It may have arisen from the parotid gland, and it rapidly invaded his skull and his brain, and it was fatal. It was fatal. He had no chance of survival. Now, that is distinctly unusual. It destroyed the facial and trigeminal nerves. It was actually originally presented as Bell's palsy. In my estimation, it's too rapid for the vaccine to cause the cancer. The cancer was probably already there in a nascent form, but the cancer rapidly progressed, more rapidly than we ever have seen, especially an invasive fatal head and neck cancer. Literally, he died within months. That's the primordial or prima facie definition of a turbo cancer after COVID-19 vaccination. Can we prove it that the vaccine caused the cancer? The answer is no. We won't be able to do that until we actually stain for messenger RNA and stain for spike protein within the cancer itself. And it wasn't done in that case. And pathologists are going to have to get up to speed on staining for vaccine spike protein and messenger RNA, because we do have a cancer epidemic now on our hands starting in 2021 after the rollout of the mass vaccination program. The medical community, including medical examiners and pathologists, appear to be willfully blind to the possibility that vaccination caused death. So as a routine, they are not staining for or using methods to detect the messenger RNA in tissue or to detect spike protein. We see just a handful of manuscripts coming out. The manuscripts that come out look convincing that the vaccines are causing death, including our paper by Holscher and colleagues, now published in the Journal of the European Society of Cardiology. We have a more broad paper on all the autopsies considered. Again, Holscher's the first author. I'm the lead author. It's on the European Commission preprint server right now, Otto, under peer review. But I'll give you an example I think any parent can understand. 2 boys, age 16 and 17 in Connecticut, take Pfizer vaccine. And on days 3 and 4 after Pfizer, they're found dead in bed by their parents. No opportunity for CPR, no opportunity for emergency care. They literally are dead in their bed. The parents are outraged. The Connecticut recorder does an autopsy. He's not sure what's going on, but he calls in University of Michigan and University of Minnesota pathologists. They do the appropriate staining, and they conclude it's COVID-19 vaccine-induced myocarditis. With these 2 cases, and was published in Archives of Pathology, there should have been an immediate halt to any adolescent and childhood vaccination. No one should face the possibility of losing their child after taking a vaccine and having it become so clear-cut in the medical literature. You know, the first paper that was published was by Verma, and that was in New England Journal of Medicine. There was a woman who was vaccinated, and she died. She died of fatal myocarditis. The next one was by Choi in Korea, a man 22 years old. He takes Pfizer, and he develops chest pain for about 5 days or so. He goes in the hospital. He dies in the hospital 7 hours later. They can't save him with all the resuscitative equipment. And at autopsy, the vaccine had destroyed his heart and the conduction system. These are convincing cases that should have brought the vaccine program to a halt, but yet the medical community is willfully blind to these deaths. It's impossible to forecast or ascribe motive to what's going on in the minds of practicing doctors right now. Reporters are not asking them questions. Reporters are asking other people who understand what's going on questions, but they're not asking the right people questions about why aren't they concerned about this. To my knowledge, there's no grand rounds on vaccine injuries, disabilities, and deaths. The Biden administration, HHS, has spent over $1 billion on long COVID, but no investment in vaccine injuries. And even in that, they've turned up nothing. No new drugs, no new protocols. I think the average doctor is willfully blind because they've taken the vaccine themselves, probably multiple injections. They've promoted it among their family members. They've told their patients they should get the vaccine. And now it is psychologically impossible for them to come to the internal recognition that this has been a disastrous mistake for their own health and for the health of their family and their patients. This is so psychologically damaging. This is very similar to the days when doctors smoked and doctors advertised cigarettes. And doctors were convinced that smoking was safe. And they wrote articles saying that smoking was safe. It's identical. It took 40 years for doctors to come to the full recognition that they were gravely wrong. Here we are 3 years into this vaccine campaign, and there's no major chief of medicine in the United States who's come out and said, listen, I've changed my view. The vaccines aren't safe. Nothing. It's a stonewalling of America. The very first warning sign or the point of detection is actually the injection in the arm. It's very important. In a paper by Schmeling and colleagues, and the US CDC VAERS data corroborate this, and Senator Ron Johnson's evaluated, found the same thing. A third of people who take the shot, just under a third, about 30%, who take a shot, no side effects, none. No pain in the arm, no fever, no inanition, no reactogenic symptoms at all, as if they got a placebo. And as far as we can tell to this day, they're perfectly fine. So I tell every patient, think back to when you got the shot or your family member and, were they okay or were they not? It's very, very important. Now, about 2/3, just under 2/3, have some mild side effects, but nothing lingering, nothing major. And multiple studies show it's somewhere between 5 and 10%. Those are the patients we're worried about. They had, within a few days, a severe reaction, could not go to work, nausea, vomiting, fever. And then from there, the syndromes developed. So in the Schmeling paper, that was 4.2% of doses. In the CDC VSafe data, 10 million Americans who completed the data form on their phone, There, 7.7% of recipients got so sick immediately, they had to go to the ER, urgent care, or be hospitalized. So I think people know who they are based on their initial reaction. Now, those who have initial reaction should be wary of symptoms. Chest pain, effort intolerance, dizziness, passing out, those are all signs of myopericarditis or another cardiovascular syndrome called POTS. Individuals who develop loss of vision, hearing, seizures, numbness and tingling that ascends the body called Guillain-Barré syndrome. These are all signs of neurologic damage, well-described neurologic damage with the COVID-19 vaccines. Blood clots like we've never seen before. Blood clots that go from the ankle to the hip spontaneously. In a paper from the FDA by Wu and colleagues, they describe thousands of blood clots. Large ones like we've never seen before, and in 11%, they're fatal. So I tell patients, listen, pay attention to the size of both legs, unusual swelling or pain. Be wary on long car rides, plane rides, after hip or knee surgery. After vaccination, the body is hypercoagulable. It is more likely to form blood clots. Very, very important. Fourth area is immunologic abnormalities. Individuals with skin rash, blood in the urine, change in urination, joint pain. These are all signs of autoimmunity, autoimmune syndrome. And now, by convention, there's multiple blood tests that I order in patients where this is a concern. We measure blood tests because we're seeing months to years after the vaccine, continued expression of the vaccine spike protein and potentially other protein fragments from a process called frame shifting as it reads Pfizer and Moderna. These proteins expressed on the cell surface are causing the body to attack itself. So these critical blood tests, and this is in the peer-reviewed literature, and patients should know these terms, are the ANA, the anti-nuclear antibody, the ANCA, anti-nuclear cytoplasmic antibody, the anti-citrulated peptide, and then rheumatoid factor. I routinely order these tests for autoimmunity. So people can start to become conversant on this. Many patients say, Dr. McCullough, do I have the vaccine in my body? Do I still have it in my body? Well, what we know there is a paper by Castriuta and colleagues found a messenger RNA circulating in the bloodstream for 28 days. That's as long as they looked. In a paper, there's 3 papers, one by Ogata, Swank, and the best one by Brogna. All of these citations are available on my Substack, Courageous Discourse. Everything I'm disclosing on this interview is all evidence-based. It's all factual. It's all correct medical information. These 3 papers, and particularly the Brogna paper, found circulatory spike protein from the vaccine. And there's a way to identify vaccine spike protein versus from the natural infection. Brogna and colleagues, a German collaboration, found it widely circulatory for 6 months or longer in about half of recipients. So right now, we anxiously await the spike protein assay that we can order through commercial labs here in the United States. Right now, it's not available. So our surrogate is to measure an extended range antibody assay against the spike protein. And so when we see very high level of antibodies, that means the persistence of high quantities of spike protein. Now, even though the vaccines don't work to stop COVID, these antibodies, which actually don't stop the virus, they are measurable, and they are a telltale sign that patient is loaded with the vaccine spike protein. Many patients ask Dr. McCullough, listen, I made a mistake. What can I do to try to reduce my risks of vaccine spike protein damage in the human body? The Biden administration has spent over $1 billion on long COVID. No new ideas, no protocols, no new drugs, nothing. Myself and Dr. Proctor in our clinical practice have been working on this now for 3 years in the vaccine campaign. Many different approaches have been tried. And what we found is that symptoms can be improved, but the overall disease process is not changed unless we can help the body detoxify from the spike protein. So in 2 seminal publications, one in the Journal of American Physicians and Surgeons, the other one is in the PubMed listed journal Curious, we have published McCullough Protocol base spike protein detoxification. And what that involves is the use of oral nattokinase, 2,000 units twice a day, starting dose, oral bromelain, 500 milligrams once a day starting dose, complemented by curcumin, 500 milligrams twice a day. We combine it with piperine, 5 or 10 milligrams to get it to be absorbed. This combination has a sufficient evidence in the peer-reviewed literature on helping the body clear spike protein and reduce the effects of spike protein inflammation. Now, it's a base. It's a starting point. These are low doses. We can increase the doses if they're well tolerated. They're taken in between meals for a maximum effect. We commonly add other drugs. If there's signs of autoimmunity, for instance, we add hydroxychloroquine. If there's signs of persistent infection, we can add ivermectin. If there are significant signs of pleural pericardial problems, we can add colchicine. Brain fog, neurologic symptoms, we can add additional drugs, including a nicotine patch or oral acyclovir, low-dose naltrexone. So treatment of a COVID-19 vaccine injury syndrome starts with the base. And our experience is if we don't address the spike protein, it's not going to get better. Then we add on other drugs. Other clinics helping patients all have developed their own styles. I want to reference the World Council for Health, which has listed a whole variety, probably about 36 different drugs or supplements that could be tried. Frontline Critical Care Consortium has done the same. But there's a difference between just kind of a list of drugs and a protocol. The McCullough protocol, based spike protein detoxification, gives the constructive steps, the medicinal agents, and the doses, and it gives, I think, direction on just how to manage it. Very similar to McCullough protocol for acute treatment of COVID-19. These have been breakthrough. Worldwide now, McCullough protocol-based spike protein detoxification has become the de facto standard. There are no new treatments that have arisen out of COVID research for the cancers themselves. So the cancers themselves are subject to the traditional forms of surgical, medicinal, and radiation treatment for cancer. However, in a recent paper by Salvina and colleagues, what was demonstrated is that the cancer patients are vulnerable to acute COVID-19. And in a paper recently published in JAMA, all the cancer patients were vaccinated for COVID-19, and the vaccines were completely useless. Patients got infections anyway. And so what the doctors did is they used the combination of silgavivimab and tixagevimab, which are long-acting monoclonal antibodies against SARS-CoV-2, and they did reduce the rates of infection. Now, sadly, this antibody combination, which is a long-acting, can be given every 6 months, it's safe and effective, but sadly, it was pulled off the market by the US FDA prematurely, even pulled off before Europe did. The FDA has pulled monoclonal antibody after monoclonal antibody off the market for theoretical concerns that it may not work against new strains. And in a tremendous double standard, the FDA has not pulled off the vaccines where it's clear the vaccines aren't working against novel strains. So the monoclonal antibodies are subject to FDA withdrawal, and the vaccines are not. In fact, the FDA has not removed any single vaccine for safety and efficacy. The vaccines have just been retired at the decision of the drug companies, not the FDA. McCullough Foundation was started in 2022 in collaboration between myself and best-selling true crime author John Leake. And it was in response to so many people around the world asking, Dr. McCullough, how can we support you? The best way is through tax-free donation, a 501c3 organization, and we formed it. It's been incredibly successful. There are 4 major missions of the foundation. The first is investigative scholarship, like so many of the manuscripts that I've quoted today are supported by the McCullough Foundation. The second is media, like filming this program today, and as many of you know that I'm on national TV multiple times per day through the pandemic, and certainly on a weekly basis. I am the lead in terms of providing a counter narrative. We hear a government narrative, and people listening want to hear the counter narrative. Now, I've been a critic of the government response, but I also have provided solutions both for acute treatment and now management of vaccine injury syndromes where our government has offered nothing. The third area is in the legal system. Myself and those who are going to work with me are involved in over 100 cases, legal cases, defending people's civil rights, defending medical freedom. 2 of my testimonies and expert reports have gone all the way to the U.S. Supreme Court and resulted in decisions in favor of medical freedom. Well, all of that court work is done pro bono. So McCullough Foundation supports the research, reporting, the other work that's needed to perform in these cases. And then the fourth area is in public policy. As many of the listeners will know, I've testified 3 times in the U.S. Senate and now recently before U.S. Congress, January 12, 2024, multiple states' senates. I am on a standing committee now in Arizona for both the House and the Senate of Arizona. All of that expense now is handled by the McCullough Foundation. I'm very grateful for the support. So again, to summarize, McCullough Foundation, independent scholarship, media, the justice, and public policy. And we're pleased to announce we're hiring our first clinical fellow to train under myself and John Leake, and that's Nicholas Holscher, who's going to be a Master's of Public Health graduate from the University of Michigan. He's committed. He'll be working with us for a full year. And as we become more successful, we'll take on more scholars and hopefully build out a core group. Our aim is to raise $10 million to have an operational budget to fully fund what we do in McCullough Foundation. And we're very grateful for all the support we receive from listeners like you, those watching this program today.